So next in the topic is Parkinson's disease and sleep. So before I proceed, I want to briefly introduce myself. I forgot to do it at the beginning. I thought I take care of all of you guys, but not exactly. I hope a lot of you know Dr. Asher. Most of you were his patients, and when he retired, I and Dr. G took half each of his patient load. And since then, I've been dealing with Parkinson's disease, and I really love it. But my main background is in sleep medicine. I come from South India, and I finished my residency at MU and did my sleep fellowship. So I see a lot of sleep and a lot of Parkinson's disease patients. And sleep problems are very rampant in Parkinson's disease patients, and that's what we are going to talk about. So before I proceed, a few disclosures. I don't have any conflict of interest, and the content in these slides is obtained from the internet, and it's not my own. And this is purely used for educational purposes. So I would like to start my presentation with a very good saying on sleep. The best bridge between despair and hope is a good night's sleep. This actually tells you a lot. It has a lot of scientific basis and a lot of philosophical basis as well. And as I proceed, as I talk more about sleep, and you will understand how important it is to have a good night's sleep, and how sleep disruption due to various sleep disorders can affect the quality of life. So before I talk about sleep disorders, I want to briefly talk about normal sleep, normal wakefulness, what happens when we sleep, all that stuff. So I'll give you a small foundation so that you'll be able to understand my subsequent slides where we talk about the disorders very well. So all of us sleep, right? We human beings have a biological need to sleep. Most of us sleep during the nighttime, except for people who do shift work where they sleep during the daytime. But most of us do sleep during the nighttime. When we go to our bed and try to fall asleep, it should not take a lot of time for us to fall asleep. So the transition from wakefulness to sleep should be pretty smooth and pretty quick. If there is a lot of time that a person needs to fall asleep, then that is a problem. And we'll talk about that. Once we fall asleep, we transition from a lighter stage of sleep into a deeper stage of sleep. The lighter stage of sleep is immediately when you fall asleep, and gradually you will move forward. And there are two main types of sleep. One is called non-REM sleep, one is called REM sleep. REM sleep stands for rapid eye movement, REM. So basically, during this portion of the sleep, which is about 15 to 20%, we have rapid eye movements. We keep our eyes closed, but the eyes constantly move. So this is why it is called rapid eye movement sleep. And the other portion of the sleep, which is the bigger chunk, does not have any rapid eye movements. So we call it non-rapid eye movement sleep, NREM. And even in this NREM sleep, we technically divided that into 3 stages. Stage 3 is considered to be the deep stage of sleep, the restorative portion of the sleep. So when we start our sleep cycle, we transition from non-REM sleep into REM sleep. Again, back to non-REM sleep and to REM sleep. And this cycle is about 90 minutes, give or take 10 or 20 minutes plus or minus. We usually do this cycle. Non-REM, REM. Non-REM, REM. We have about 4 or 5 cycles every night, and we eventually wake up. For us, the amount of sleep we require changes based on our age. When we were babies, our sleep need was a lot. We needed 18 to 20 hours of sleep. But by the time we reach 20 25, our sleep need shrinks down to roughly 8 hours. There is a small group of people who require at least 10 hours for them to feel refreshed. On the other hand, there is a small group of people who doesn't need 8 hours, they just need 6 hours. Those who need shorter sleep cycle or shorter sleep time, they're called short sleepers, and those who need longer sleep time are long sleepers. But overall, 8 hours is what we usually need. As we get older, that 8 hours is also not necessary. We just need a little less than that. 5 to 6 hours by the time you reach 60 or 70. That's pretty much what we need. Usually, we don't need an extra nap during the daytime when we are younger. But in the afternoon, around 1 or 2, we feel slightly drowsy, the time of siesta. And biologically, our alerting systems also slow down at that time. So, though we need a full night's sleep, we feel a little drowsy in the afternoon time, and that is normal. That has nothing to do with the food that we consume, though having a huge meal would make it worse, but we biologically have a slight dip in the level of alertness. And that dip gradually widens as we get older. So as you go into 6th decade or 7th decade, you need 5 to 6 hours of sleep during the nighttime, and during the afternoon time, you tend to take a small nap, and that's normal. So that is the normal sleep cycle and the changes we would see as we get older. When we sleep, it's supposed to be a constant, continuous cycle of sleep without any significant interruptions. You may just quickly wake up 1 or 2 times a night, but should go back to sleep without any problem. So whatever sleep you get should be a continuous 6 to 8 hour long sleep during the nighttime. So this is how normal sleep should look like. In Parkinson's disease, if you take out other sleep disorders, even after taking those into account, we still see a reduced sleep time. The nighttime sleep has a lot of arousals. It's not a single consolidated sleep. You have a lot of arousals. You have reduced sleep efficiency. And when we sleep, it is important to understand how our breathing operates, because one of the sleep problems that we see in Parkinson's disease patients is sleep apnea. To understand sleep apnea, I'm going to briefly talk about how we breathe during the nighttime. When we are awake, we have a voluntary control on our respiration. You can breathe in fastly, or you can slow it down. You can control the respiration using your mind. However, when you are sleeping, the big portion, the big chunk of the brain wants to actually take rest. Sleep is because the brain wants to take rest. So when the brain that controls almost every single thing in the body wants to take rest, what happens to breathing? How can we not breathe? Well, we have a mechanism in place that takes over the control of respiration. That mechanism is situated in the back portion of the brain, which operates automatically. So when you transition from wakefulness to sleep, you automatically start this mechanism that operates the entire night, that keeps you breathing the entire night, that prevents a living being from dying because of not breathing the entire night. So this automatic mechanism is situated in the back of the brain. And the proper functioning of this mechanism is very important to our survival. And in the subsequent slides, I'll show you what happens in certain sleep disorders and why the automatic mechanism is important. All right. Now let's talk about one of the most common sleep disorders that we see in community, sleep apnea. What is sleep apnea? As I just mentioned, when you're sleeping, Your breathing should be smooth, should be uninterrupted, should not have any fluctuations, because the automatic mechanism will ensure that your breathing continues to happen smoothly while you're sleeping. But when that smooth flow of air is interrupted, then there is a problem. The brain that is supposed to be taking rest now understands that, hey, the breathing is not happening properly. I got to wake up. I got to do something. I got to make the breathing happen regularly so that this organism, this living being will survive. So the brain can't take rest, can't rest in sleep when there is breathing fluctuation that happens during the nighttime. That's exactly what sleep apnea is. And there are various different types of sleep apnea. The most common one is obstructive sleep apnea. And there is a rare condition called central sleep apnea. I just told you that the back of the brain has automatic control centers for breathing. So if those automatic control centers don't function well, brain stops producing signals to breathe properly. So that is basically what central sleep apnea is. If your brain centers for respiration are under the influence of medications, or you had a stroke in that region, or there was MS related problem in that lesion, so whatever the reason be, if you have problem with the automatic centers of respiration, the brain does not make you breathe in and out properly during the nighttime, and that is central sleep apnea. It's a not very common form of sleep apnea, a rarer form of sleep apnea. But what is obstructive sleep apnea? This is actually more common than central sleep apnea. And to explain the obstructive sleep apnea, I have a picture for you. The picture above shows the normal anatomy when you're sleeping, where the airway, the passage for air, should remain patent so that the air can move in and out freely. However, if the pathway for the air is not open, if it is collapsed, then the air cannot move in and out easily, and that results in disturbance in the airflow. That results in the brain waking up. The muscles that maintain the caliber of the airflow will actually become so loose or so narrow that during the nighttime, this passage collapses. That's basically what obstructive sleep apnea is. Obesity is a huge risk factor for obstructive sleep apnea. As you can imagine, if more fat gets accumulated around that airway that's going to become slightly narrow during the sleep becomes even more narrow. And that increases the risk for obstructive sleep apnea. And this is a very common problem, not just in the community, but also in people with Parkinson disease. There are so many different mechanisms that operate in obstructive sleep apnea in Parkinson disease, more than what mechanisms you see in a non-Parkinson disease patients. How do we treat this obstructive sleep apnea? Well, we just learned that the airway collapses during this obstructive sleep apnea. So if we can prevent the collapse of the airway, then we can let the air flow in and out smoothly and can treat sleep apnea. And one common treatment for obstructive sleep apnea is CPAP therapy, where you put a continuous positive pressure in the airway, inflating it like a balloon, splinting it open like a balloon, so that the airflow can continue to happen without interruption. So positive airway pressure therapy is the first line of treatment for this obstructive sleep apnea. So that is with regards to sleep apnea. Now let's come to a very common sleep disorder, actually the most common sleep disorder in Parkinson's disease patients, insomnia. In the initial slides, I was discussing about how we transition from wakefulness to sleep, right? The transitions should be smooth. You should not take a whole lot of time from wakefulness to go into sleep. However, if you have a problem falling asleep, or if you have a problem maintaining the sleep continuity, that is insomnia. Even if you have the opportunity, when you have the adequate opportunity, when all the circumstances are permitting you to sleep, if you still have trouble falling asleep, then that is insomnia. As I said, it is the most frequent disorder in Parkinson's disease population. The important factors in the development of insomnia include female gender, duration of the disease, and presence of mood disorder. In other words, if you are a female with Parkinson's disease, you are more likely to develop insomnia compared to a male person with Parkinson's disease, assuming equal age and severity of the disease. The longer the duration of the disease, the more likely you're going to develop insomnia. If you have a coexisting mood problem like depression or anxiety, you're more likely to develop sleep apnea. How do you address insomnia? Insomnia can be a very bothersome problem. How do you address it? Well, sometimes the cause for the insomnia is poor control of the motor symptoms of Parkinson's disease. For example, people with tremor, it's a resting tremor. When they go onto the bed to fall asleep, the hand may continue to shake. And when it continues to shake, it can prevent you from falling asleep. So there, the insomnia is not due to something else going on. It's basically the symptom of Parkinson's disease that is preventing you from falling asleep. Sometimes you might wake up in the middle of the night with legs stiffening up. That can be an inadequately treated motor symptom of Parkinson's disease. So sometimes the key to treating the insomnia in these patients is properly correcting the motor symptoms of Parkinson's disease. I also said that the presence of mood disorder will increase the risk of sleep apnea. So if someone has anxiety or depression, they can be causing insomnia, or they can be making the insomnia worse. So address the mood problem if there is a mood problem. Then there may be other sleep disorders going on that might be causing insomnia. Try to address them. Restless leg syndrome, periodic leg movements in sleep, some of the things we'll discuss, can also cause insomnia. So address those sleep problems, and that can help with insomnia as well. Pain is a very common complaint in Parkinson's disease population. So if you have pain-related problems and that is causing insomnia, go ahead and address the pain. Despite addressing all the other causes of insomnia, if you still have it, then try cognitive behavioral therapy and or medications. And obviously, the assessment of insomnia is not a very simple, straightforward task. The clinician has to look at all the different aspects of sleep and figure out where the problem is and figure out the right treatment. Quickly jumping onto medications is never a good idea. So someone with Parkinson's disease having insomnia, the treating physician has to assess a lot of different things before making the intervention. The next important sleep problem in Parkinson's disease population is excessive daytime sleepiness. Up to 1/3 of Parkinson's disease patients can have excessive daytime sleepiness. As the disease advances, the incidence of excessive daytime sleepiness also increases. And the excessive daytime sleepiness can have a significant impact on the quality of life in Parkinson's disease patients. The most important thing here is early recognition and management. It can masquerade as so many other things, but if you analyze the day-to-day activities of a PD patient, a lot of them will have excessive daytime sleepiness, which is actually preventing them from doing the things they want to do. This inability to do the things they want to do might be attributed to so many other things. But if you carefully analyze, excessive daytime sleepiness could be there, making things look worse. So, addressing this problem can have a significant positive impact on the quality of life. Why does sleepiness actually happen in Parkinson's disease patients? Well, sleepiness and wakefulness is a mere balance between chemicals that make you sleepy and the chemicals that keep you alert. So you can easily understand that if one set of chemicals are low, the other set of chemicals will have an advantage and do the things they are supposed to do. In Parkinson's disease, what happens is there is damage to various different brain systems. As a part of that damage, the alerting systems of the brain can also get damaged. And guess what would happen? There is a relative advantage to the sleepy systems. That can make you sleepy. What else can make you sleepy? Well, the medications that are used to treat Parkinson's disease, a lot of them have sleepiness as their side effect. So the medications you take to control the motor symptoms can also make you sleepy. But the problem is, the motor symptoms are also very bothersome. And you have to use these medications to have a good quality of life. Otherwise, the symptoms cannot come under control. So at times, we have to make compromises. But at times, the clinician can try to look for alternatives for medications which do not have this much sleep potential. Parkinson's disease usually happens as we get older. So a lot of other medical comorbidities may be present. And if some of them are not treated properly, they can also be making the sleepiness happen or making it worse. So the clinician has to look at all the other things that can contribute to excessive daytime sleepiness and try to address the other medical comorbidities. And patients may have other sleep disorders making their nighttime sleep bad. When you don't get a good night's sleep, we all know what happens. You will be sleepy during the daytime. So guess what? If a Parkinson's disease patient has sleep apnea or other sleep disorder that is fragmenting their sleep, that is preventing their brain from getting a good night's sleep, they will be sleepy because they are not getting a good night's sleep. So when assessing the excessive daytime sleepiness, the clinician has to look at all the various different things that can contribute to the excessive daytime sleepiness. How do we manage that? Well, the first thing should be non-pharmacological intervention. Do not jump into treating a problem with medications. And that's my philosophy. Treat with as less many medications as possible. Use other non-pharmacological strategies. Otherwise, within no time, we'll end up with a ton of medications. So even with this excessive daytime sleepiness, non-pharmacological measures. First, have a good sleep hygiene. Good sleep hygiene includes habits like not drinking coffee after 4 p.m. or 5 p.m., not smoking a cigarette, because those things can keep your brain alert. Don't watch TV in your bed. Only sleep in your bed, but not do any other activities. Don't go out on a hike just before you go to bed. Do exercise. That's good. But don't get your body activated just before going to sleep, because your body wants to rest. When you are done with rigorous physical activity, it still is very charged on and it can't fall asleep quickly. So don't do these activities. Don't use a lot of smartphones, watch TV shows on smartphones, that kind of stuff, because we now are realizing the effects of blue light in the screens of the smartphones that can adversely affect our sleep. So all these good sleep hygiene will help with some of the daytime sleepiness, because if you get a good night's sleep, you're going to be less sleepy during the daytime. As I mentioned, medications can be a significant contribution to the sleepiness, so discuss with your clinician to see if there are alternatives for your dopaminergic medication. See if there are other medications that can result in less sleepiness. If you have other sleep problems like sleep apnea, go ahead and get that sleep apnea addressed. By addressing those sleep problems, you are letting your brain have a good night's sleep. And a brain that gets a good night's sleep is going to be alert the next day. And if you have a mood problem, address that. Because untreated, mood problems like anxiety and depression can cause insomnia. And they can also cause sleepiness by themselves. So if you have a mood problem, do not hesitate to discuss that with your clinician. Because as Dr. G mentioned, depression and anxiety are just part of the disease. They don't necessarily come because you are concerned about the disease. They're just part of the disease. So don't hesitate to discuss your mood problems with your healthcare providers. If all of those things are already addressed, and if you still have excessive daytime sleepiness, then we use medications to make your brain alert. We use medications to augment the alerting chemicals in your brain so that you can stay alert during the daytime. Medications like modafinil, methylphenidate, sometimes plain old coffee, and having some strategic naps during the daytime. So it's a combination effort. Medications addressing other issues that are causing excessive daytime sleepiness can help with the reduction of excessive daytime sleepiness. And as I said, this can be a significant contributor to the poor quality of life during the daytime. Now let's talk about restless legs syndrome. Now I put a couple cartoons, I thought kind of funny. But what is restless leg syndrome? As the name suggests, there is restlessness in the legs. Though the disease was initially described in legs, the same restlessness can happen in arms or the entire body, but most of the times this disease affects the legs. People will have restlessness. This restlessness can take various different forms. Some people say, bugs are crawling on my legs. Some people say, soda is flowing in my blood vessels in the legs. Some people tell that they have intense pain. So there are so many different descriptions for the same discomfort in this restless leg syndrome. This discomfort is mainly seen in the evening or night times. When it first starts, people will experience this discomfort when they are on their bed, fully relaxed and trying to fall asleep. All of a sudden, they realize that their legs are causing them a lot of discomfort, causing them a lot of pain. And this discomfort should respond to moving the legs or getting up and walking around. And this discomfort would get worse if you keep the legs still. If someone has all these features that I mentioned, that is basically restless leg syndrome. It's not exclusive to Parkinson's disease population. It is very prevalent in the community. Up to 5% of the general population can have some sort of restless leg syndrome. In Parkinson's disease, it tends to be slightly different. It tends to be relatively milder. It tends to start relatively late. Usually, patients with Parkinson's disease and restless leg syndrome, they don't have a family history of restless leg syndrome. And it usually responds to the dopaminergic medications that we use to address the other symptoms of Parkinson's disease. So you get treated for your restless legs with the same medications that are being used to treat your tremor, stiffness, or slowness. So that is restless legs. Despite this, it can still be present. It can still bother patients. It can still make it difficult for you to fall asleep. So if you see any of these symptoms, address this with your clinician. Restless leg syndrome can be treated with, as I said, Parkinson's disease-related medications. And there are other medications that can be used to treat restless legs also. And treating restless legs will help with the quality of life issues and help with the daytime sleepiness as well. The next important disorder that I want to discuss is REM sleep behavior disorder. And to describe this disorder, I did not put a lot of content. I just put a few figures. I want you to just look at the figures. And this is a cartoon strip from Calvin and Hobbes. Calvin is a young boy, and Hobbes is his teddy tiger. And here is what is happening. The teddy tiger wakes up in the morning and tells, "What a peculiar dream I had last night. I dreamed I was in a big fight with a ferocious weasel. What do you suppose it means?" Then Hobbes wakes up and tells, "It means you're sleeping on the floor tonight." So what happened here? This teddy tiger had a violent dream. And in this violent dream, instead of having the dream just go on in its brain, it actually acted out of the dream. It actually started to fight, started to act like it was fighting. And that resulted in a lot of injuries to his friend. And this is a very important story because this is basically describing REM sleep behavior disorder. If you go back to my initial introduction to the sleep, there was a small portion of the sleep called REM sleep, right? Rapid eye movement sleep. And this constitutes about 15 to 20% of our sleep at nighttime. And during this REM sleep, we have the vivid dreams. So whenever you think about a vivid dream that happens to you, it is happening in that REM sleep. But when there is a vivid dream going on, it can become a physical manifestation. You can physically act out of those dreams. So God has given us a protective mechanism that operates during your REM sleep and prevents your dream from being acted out. So all of us are born with protective mechanism that prevents our dreams from becoming physical manifestations. But in Parkinson disease, that protective mechanism can get damaged. And guess what happens when it gets damaged? The dreams that they're having now will start to come out of their limbs, come out of their body. Whatever they're dreaming, it is actually being physically enacted. And that can be dangerous. The important thing about REM sleep behavior disorder is this problem can start many years before patients develop tremor or stiffness or slowness. So this is considered as one of the early predictors of Parkinson's disease, early predictors of Parkinsonian disorders. This can also start after you are given the diagnosis of Parkinson's disease. It is very frequent. Up to 50% of the Parkinson's disease patients will have this REM sleep behavior disorder. In some form, it can be very severe or it can be very mild. But the thing is, this REM sleep behavior disorder can result in dream enactments, can make the patient act out of dreams, and during that acting out, they can injure themselves by hitting onto walls and stuff, or they can injure the partners. So we have had cases where patients fell down from their bed because they were acting out of a dream. We have had patients where spouses got beaten up in their sleep because the patient was acting out. And here, the patient wouldn't know that he is acting out because he is actually in sleep. He is dreaming, but he is acting out. Doesn't know that he is even acting out. So, if your spouses are reporting that you are having something like that, you need to discuss this with your clinician because it can result in significant injuries to the patient or to the bed partner. Maintaining safe environment is very important because, as I said, injuries can happen. So first thing is maintain a safe environment. Have some soft pillows or something on the floor so that if you roll down and fall, at least you would not injure yourself that much. Some medications can exacerbate REM sleep behavior disorder, like antidepressants. So the clinician should make a decision whether to continue the antidepressants or to discontinue them. If nothing else is working, melatonin can help. Medications like clonazepam, they can help. Sometimes we got to use a combination of melatonin and clonazepam. And sometimes nothing works. It only gets better with medications, but still the patient continues to have this problem. At that time, having a safe sleeping environment is the key. So, a lot of the times, this needs to be brought up by the bed partner. The patients wouldn't know this. So, every time you see your Parkinson disease doctor, if there is something like this, you should report that to your doctor so that he can assess what the problem is and try to address it before it causes us a lot of grief. Then another problem that PD patients face is nocturia, which is 2 or more episodes of urination that happens during the night, and that can cause sleep problems. 2 or more episodes of urination can be seen up to 80% of the patients. And 1/3 of the PD patients can have up to 3 episodes of needing to urinate at nighttime. It gets worse as the disease progresses. So, what do you do about this? Well, try to minimize the consumption of water around bedtime. Try to drink more water during the daytime and try to cut it down as much as possible during the nighttime. If you have other problems like prostate issues, sometimes sleep apnea can also result in this. So try to address those problems. And if those things won't work, try medications. So nocturia can be a sleep-related problem in PD patients, and try to discuss this if this is causing you to have poor sleep at nighttime. Sometimes addressing it can be straightforward. Sometimes it can be a difficult thing to address as well, but whatever the case is, you need to discuss this with your clinician. I also wanted to briefly mention about the effect of DBS on sleep. A lot of people whose symptoms don't respond to the medications, especially people with tremor, they go with DBS. And after my presentation, we have a great presentation on DBS. Dr. Siddiqui is going to talk about DBS and a lot more details on it. But DBS can actually help with sleep. It can help maintain the sleep more consolidated. We don't know why this happens. It could be just the direct effect of DBS on the sleep, or it can be because DBS is making your motor symptoms better. Maybe by making the motor symptoms better, it is letting you to have a good night's sleep. We don't know, but DBS can help with sleep as well. Having said all these things, a lot of medications that you take for Parkinson's disease, be it the medications to help with your motor symptoms, medications that are used to address other associated symptoms, a lot of them influence the sleep. So it's not just the various sleep disorders that you might be having, it's the medications that you're on that might be making your sleep worse as well. So the bottom line is, sleep problems can contribute to a lot of morbidity. It can reduce the quality of life. Identification of the sleep problems is very important, because if you address the sleep problem, if you let the person have a good night's sleep, all the other things will start to feel a lot better already. If you don't address them, the quality of life goes down. And when trying to analyze a sleep problem, do not jump to medications right away, because there are so many other areas where the clinician can intervene. And some of the sleep problems, if untreated, can also increase the risk of other diseases like sleep apnea. If you don't treat it, it will increase the risk of hypertension, it will increase the risk of stroke, heart disease. So addressing the sleep problems, identifying them, it's very important to help with the quality of life, to reduce the risk of other chronic medical disorders, and it can also make your motor symptoms look a lot better, look more responsive to the medications you are on. So with this, I'm going to conclude my presentation, and I'm ready to take any questions if you have any. So first question is, aren't anticholinergic medications discouraged for PD patients? Yes, they are, but sometimes you have to balance between risk and benefit. People without significant cognitive problems, they can tolerate anticholinergics okay. In fact, the medication amantadine has anticholinergic activity, and that's how it actually helps the tremor. Second question is, what non-pharmacological treatments do you recommend for nocturia? Well, cutting down the amount of water you consume, having an alarm to quickly wake up, go to the restroom, come back and go back to sleep. In some patients, adult diapers, that can help. Address sleepwalking. Sleepwalking is usually not seen in adult patients. It is usually a problem in kids and youth. People usually grow out of sleepwalking. And the sleepwalking is not necessarily related to Parkinson's disease. It can be seen in non-Parkinson's disease patients also. So you don't have any increased risk. But if you have sleepwalking, then definitely all the safety measures will be applicable to that. And sometimes if the safety measures don't work, you have to treat that sleepwalking by using medications like clonazepam. Sometimes there are other sleep disorders that might be making the sleepwalking happen, and sleep apnea is one of the most common ones. So address the sleep apnea. That can help with sleepwalking as well. What are the other diseases that cause aggressive REM sleep? So I'm assuming, so the question is, what are the other diseases that cause aggressive REM sleep? I'm assuming aggressive REM sleep, they are referring to REM sleep behavior disorder. It's not just the Parkinson disease. Most of the Parkinsonian syndromes that Dr. G mentioned have REM sleep behavior disorder. In fact, multiple systems atrophy is the most common disease associated with REM sleep behavior disorder. Sometimes REM sleep behavior disorder can happen even in non-Parkinsonian disorder patients. It can happen in youngsters also. Antidepressant medications, most of them can result in REM sleep behavior disorder. And there is a lot of research on this field where some argue that the presence of REM sleep behavior disorder early on, even in the youngsters, could be a sign that they might develop Parkinson's disease in the future. So to answer that question, other Parkinsonian disorders, and sometimes can be seen in the setting of usage of antidepressants. What is a healthy amount of time for an afternoon nap for seniors? Well, roughly 20 to 30 minutes, no more than that. The reason is, when we go from an awake state into sleep, we transition from a lighter sleep into a deeper sleep. We want to wake up before the deep sleep sets in. That is the reason why we should not go more than 30 minutes. Because if the deep sleep has kicked in, if you wake out of the dream sleep, a deep sleep, you will be very groggy. And that's called sleep inertia. And that grogginess can continue for the next few hours, can make it feel like you're actually way worse with the nap than you're not. So it's very important to keep the naps small so that you will just wake out of one of the lighter stages of sleep and not from a deep stage of sleep. Is vivid dream a color common? Are you referring to a vivid dream having a lot of colors? I'm unable to understand the question. In a vivid dream, it can be very colorful. That's what happens in REM sleep. You will dream with a lot of detail in it. You'll see a lot of colors. You'll see fine details of people. So that is what a vivid dream is. In that, you can actually see a lot of colors as well. Is there any connection between sleep apnea and swallowing difficulties? If not, what causes the swallowing difficulties? Typically, no connection between sleep apnea and swallowing difficulties. Swallowing difficulties can happen as a part of the disease. The disease, as you remember, the core feature is slowness of movements. So the same slowness and the stiffness applies to the swallowing muscles as well. So there will be swallowing difficulties typically as the disease advances. Is leg pain part of Parkinson's disease in general? Sometimes almost debilitating. That is 100% true. It can be very debilitating. It is not necessarily a part of the Parkinson's disease, but as I said, pain is very, very common. Sometimes we have reasons for the pain. Sometimes we don't have reason for the pain. One of the things that can cause leg pain in PD patients is restless leg syndrome. So you have to see if your pain fits the picture of restless leg syndrome. And you have to treat it like restless legs. Half the times you're successful, but sometimes you're not. And as I said, a lot of the times we wouldn't be able to find a reason for the pain, though we know that pain can be a very, very common problem in PD patients. Why do some people use BiPAP instead of CPAP? Does it mean the sleep apnea is getting worse? Not necessarily. There are various different reasons why the clinician might choose BiPAP over CPAP. One of the things is comfort. Some people might find it comfortable to have a higher pressure when breathing in and a lower pressure when breathing out. That is basically what BiPAP is. When you're breathing in, you get a higher pressure. When you're breathing out, you get a lower pressure. Comfort is one of the reasons, and there are so many other reasons. It does not necessarily mean your sleep apnea is getting worse. Some days sharp as tacks, some days are not. And that's not uncommon at all. And that is true for non-PD patients also. It has a lot to do with so many different things that go on. You can easily relate this to your motor symptoms also. Some days your symptoms look a lot better, some days they are not. Patients with headaches, some days they get headaches, some days they don't get headaches. So it just tells you that the body responds to so many different factors, be it environmental, be it food related, be it the amount of sleep, be it the amount of stress. So whatever it is, there are so many things that can influence this problem. So the answer is yes, that is very common. You're not the only one that experiences these fluctuations. A lot of them do. Could they get out of bed while dreaming? They can. They are dreaming. So we have had patients who got up and started punching, that kind of stuff. Usually they do this dream enactment while laying down. But they can get up. They can usually roll and fall down. Is there any connection between sleep apnea and swallowing? Oh, we already covered that. I think that's pretty much it. But thank you very much.